Good morning, ladies and gentlemen. I am Dr. Vishakha Kalliker, and I am going to speak to you on our initial experience with the Versailles. I'd also like to take a moment to thank Dr. Nidhi Khandelwal and Dr. Vishal Soni for being so accommodating to let me give this talk online. Now, I wouldn't want you to get bored with numbers because they are sedatives, but let's take a quick tour into how the Versailles actually looks like. Now, the Versailles robotic system has been invented by the CMR surgicals from the UK. Like any other robotic system, you want to think laparoscopically, but you want to get your surgeries done robotically. So, the main first unit of the robotic system is always the console. Now, the console is the part where you, as the operating surgeon, you're either going to sit or stand, which is one of the available facilities of the Versailles console. As the height gets adjusted, how comfortable you are while operating. It also has an added screen on top where you will look while you're operating. And along with it, there is a recording device which is inbuilt in the Versailles console where all your surgeries get recorded and then get stored on the cloud drive of the Versailles system. Now, coming to the hand controllers of the Versailles, if you are a PlayStation fan, then you will very easily transit into this system. So the hand controllers have a joystick, which is basically the camera stick, so that you can move it up or down, right or left, or side to side. It also has another diathermy unit, which is the circular unit here. Now, the diathermy can be used from the hand control, or you can attach it to the foot paddle also, as long as you're comfortable. And the clutch basically helps you so that your hands don't go far and you're just doing basic wrist movements, even if your area of interest is further up or in a pelvic surgery. If you're an avid PlayStation fan like I am, because I love God of War, the Versailles should be your to go system because you don't have much of a transit period or you don't waste much time getting used to the hand controllers. The second unit of the system is a bedside unit or the BSU. Now, the BSU is something which is slightly different here in the Versailles. So there are individual bedside units here. So if you like freedom of movement, this one is right up your alley. So the company will provide you up to 4 bedside units. You may use as many or as little as one or two, depending on what surgery you're doing. So the bedside unit has one proximal end, one distal end, and something called as the V wrist, which is very beneficial because sometimes initially if your port placement is not correct or if your ports are closer to each other, there may be some clashing of instruments. If that happens, all you need to do is move this part of the bedside unit, which is the elbow, and you may then continue progressing your surgery without any interruption. So basically, you don't need to move the whole unit or you don't need to port train the whole unit. You can just continue it by adjusting your elbow a bit. The other advantage of the Versailles is that it is basically a very open space. The console and the bedside unit, everything is open. So if you are claustrophobic, this one is right up your alley. The other thing, which is most important, are the instruments. Um, there may be some drawbacks of the instruments here, but all your basic instruments are covered. One is a monopolar scissor. Uh, these are sharp dissectors. The second are needle holders. So here there are straight needle holders which you use in pairs. There is no right hand curve or a left hand curve. So there are no separate needle holders for each hand. The third one is an atraumatic flat grasper. So people who are initially used to using a curved grasper in your left hand or a crocodile forceps will find some difficulty initially in getting used to this. The fourth instrument that they provide is a monopolar hook, which works the same way as a laparoscopic hook. The fifth instrument is a bipolar dissector. So the bipolar here is mainly used as an energy source. It is not of much use as a dissector, but with time you will get used to it. It is two prongs and it has two holes in the center, so it's not a solid grasper at the end. And the last one is a covered scissor. So basically, there is a jacket here which is blue in color. This prevents any throw of the current from an organ to the other organ. So basically, it prevents the spread of the current, and this is used as an insulating device. Along with this is how your OT setup will look once you have the Versius installed. There is also an auxiliary screen where your assistants will look at, and you have the main screen at the console. You do not require any major OT renovations to be done, which is a big advantage for this. So, whatever your OT setup is, you can very well manage to put the Versius into that. Um, they are a very user friendly group, they are a very proactive group if you need help. You also don't need to make a lot of electrical changes in your group, in your OT, I'm sorry, or any OR air handling systems change. So this can be fitted in your OT as it is. The other advantage is that since it is portable, you can move it from OT to OT. You need not keep it fixed into OT1 or label it as robotic OT. If you finish one case in one OT and you need to take and induce the patient in the other OT, you can just move all this since it is a very portable unit. This is how the OT looks for a robotic anterior resection with the ports. So you can see there is one bedside unit as the camera port and three bedside units for the instrumentation and one more additional port for your lap assistant. And the second picture here is for a robotic ventral TAPP. The ports being pretty much similar to your laparoscopic TAPP, where we've used only two bedside units for instrumentation and one bedside unit, which is your camera unit. Now, once you get over these technicalities, this is just one big chart which is there in all the OTs where the Versius is. It tells you how the port training is done, and then you instrument adjust, you do the instrument training. But all this is furthermore after you have done their formal 3-day training, and then you get to know all these things in detail. Now, coming to what challenges we faced in our initial few months or few cases using the CMR. Now, the biggest challenge we had was of the feel. So, practically, there is no tactile sensation when you're using a robotic system as you have when you're using a lab system. So, when you're doing a case like a simple cholecystectomy to begin with, we did not know how much pressure to use with our left hand grasper, and initially, we hold it so tightly that a couple of times the gallbladder actually opened up at the Hartmann's before we realized that we were holding the grip too strong. The other thing is that you keep having this sensation in your mind that your arm is connected to the robotic arm, your arm is connected to the robotic arm, which you will eventually get over after a few cases. The third most important thing, because you are constantly holding the two controllers in your wrists and your movements are only this much, you will soon realize after the case is over that only your wrists start paining, not because of the system itself, but because you've been holding it too strong. So when you're doing laparoscopy, your shoulders will pain. When you initially start robotics, your wrists will pain, but over a period of time, you will gradually know you need not hold it so strongly. The instrument will take care of itself. The Versius also eventually made some changes in their instrumentation. So the left hand grasper then started having these three black dots. So when you start to exert more pressure, it will go to three black arrows, and you know that you can slightly ease off the pressure and have the same strength. The second challenge that we faced was regarding trust. You don't know how much to trust these instruments. You don't know whether you are going to perform that well. So you don't know if you're going to trust the system, and you're not even having enough trust on yourself. The haptic boundaries suddenly become very unfamiliar. You can do the same case laparoscopically very well, but you will be very, very hesitant to do it robotically. Also, over a period of time, you do realize that the accuracy is much more, but initially you are going to, you know, be two steps a bit laid back. The other drawback that we faced was the hemostasis or the vessel sealing device. So we didn't have that. So in a fundoplication, we would still put an extra port and have the lap assistant do all the short gastrics or the initial dissection by using a harmonic or a lap vessel sealer. But one day we decided, what the heck, let's do it with the monopolar and let's just do it with the bipolar that they have given. And slowly and steadily, we realized that we should trust these instruments. They are as reliable as probably your harmonic or your sonicision or any other advanced energy source is. The third challenge that we faced was time. So if you have a big list and you're short of time, then initially you need to space out your robotic surgeries. Initially, our docking time was almost 15 to 20 minutes per case. In laparoscopy, you will put the ports and you start operating. Here, you have to put the ports, then you have to dock the whole system. From 15 to 20 minutes are now on an average docking time for every case is about 4 to 5 minutes, not lesser than that. Also, the cases that we would take 1 hour for now started taking 2 hours. So an ecclesiocardia or a Hellos myotomy laparoscopically was being done in 1 hour. But then robotically, initially because of our own fear, it was taking 2 hours. Slowly, we became time neutral because the docking time also reduced. Our accuracy and precision and knowing how the whole system works also got better. So we started to become time neutral, and once we became time neutral, we are now actually much faster. So we actually finish the cases within 45 minutes. This is also because the advantage that the robotic system has for suturing. There is no strain. You can move the instruments right, left, up, and down. So your suturing also becomes faster. The other challenge that we faced regarding suturing was we did not know how much pressure to put on the thread. Yet again, the question of feel. So initially, the threads were breaking. We were pulling them too hard. They were not being tight enough. But we did work our way through it. And we realized that all you require is just some gentle pressure and gentle manipulation to get your suturing right. The last challenge was pushing our limit. So everyone often will ask us, why would we do simple cholecystectomies or appendicectomies first? Right? So the easiest answer was, when you are in your first year or second year residency of doing general surgery, your HOD is not going to give you an empyema GB to do as your first case. You will progress from a thin wall distended gallbladder to doing an empyema GB or a shrunken gallbladder. This is the same way we progressed our journey through robotics. We began initially with simple cholecystectomies, appendicectomies, and then we started doing difficult surgeries like ecclesiocardias or fundoplications. We then slowly advanced to pelvic surgeries, where the biggest advantage of the robotic system is in pelvic surgeries. It gives you a marvelous depth and vision right into the deep pelvis, especially when you're doing things like an anterior resection or a ventral mesh rectopexy. Also, the suturing deep into the pelvis, especially for a VMR, because you have to see that you reach the pelvic floor. Your mesh has to be put on the pelvic floor and has to be sutured into the levator ani, and this becomes very difficult laparoscopically. You actually come out with a neck strain or a shoulder strain. No strain after deep suturing by the Vercius or a robotic system deep into the pelvis. Also, we started doing thoracic cases much later into our journey of robotics. And we have done quite a few now, especially robotic leiomyomas or thoracic leiomyomas. You will see that overall the field is better, the fogging is lesser for some reason, we don't know why. And your precision, accuracy, everything gets better. So you start with simpler cases and then spread your wings and then slowly push the limit or open the envelope further. And let me tell you, once you get into robotics, it's a totally different ball game. Uh, you're so fascinated by it, at least I was. I mean, I don't think I've ever felt this happy uh, getting into some new instrumentation or a new modality of management for patients. And the best part of robotics is that in the end, when you have a robotic system in your theater, when something goes wrong, as surgeons, we now have the robotic system to blame and not us. Thank you so much.